Jennifer, real quick, it says that screen sharing is disabled and I will need to share my screen. And although I'm a co-host, it doesn't want me to do that. I'm trying to do it from my secondary account though. Oh. I bet I can do this. Hold on. Okay. Here we go. Thank you. I'm going to test, make sure that is all working for us. There we go. Guys, I see that we have 3 of our board members on here. We're going to need a couple more to get going. I know Dr. Kraus was going to be opening a store this morning, was going to join us right before he did that. There's Dr. Kraus, Dr. Mack.
Can you hear me, John?
Yes, sir.
Okay, I'm sorry.
So let's see. I have 1, 2, 3, 4, 5 board members. I don't see Miss Rader or Miss 4, and I know that Dr. Mitchell is going to be out, but we have 5 and would be able to proceed. It is 9:01. So Dr. Kraus, if you're ready to go, I'm ready to go.
All right. Well, good morning, everybody, and thank you for joining us. We're going to have a hearing this morning on some proposed rules changes, and I would like to call this meeting to order.
All right, Dr. Kraus, just for the record, I'll help you out. We do have the following board members. We've got Dr. Lynn Kraus, who is running our meeting today as Dr. Mitchell is out. We've got Dr. Brian Jolly, Dr. Lenora Newsom, Dr. Debbie Mack, and Dr. Rodney Richmond. On our staff side, we do have Luke Daniel, our general counsel, along with myself, Ms. Whitmore, Ms. Bergen. I know Dr. McCready is also watching this from another room, or she may be watching it on Zoom. What I have today, we have a public notice that has been out for 30 days. I actually sent you guys a copy of the hearing procedure that I generally use. I can actually pull that up on screen for you as well. And that is really small. But the overall point of that is it's Tuesday, December 14th, 2021. It's 9 a.m. We're here at the Arkansas State Board of Pharmacy offices, also available for any participants that are interested via Zoom. We're here for a public hearing on 3 proposed rule changes. With that, we have followed the Administrative Procedures Act. We've had all of these out for public notice on the Secretary of State's website, as well as our own, with public notice published in the state newspaper for 3 separate days that were consecutive a month ago. At this time, I will open it up and I'll also pull up on screen and switch exactly what I am sharing so that you guys can see each rule in turn. First one is rule number 1, general operations. The proposed changes to that rule will update language regarding expedited licensure for qualified individuals, matching requirements of Act 135 of 2021. As a reminder for our board members, we have had expedited licensure for military members for something along the lines of 40 years or a couple more. When we did our last changes on this from previous legislative session, we had pointed out that there are many members of the uniform service that are not armed, especially given our background and knowledge of the United States Public Health Service having a large number of healthcare professionals. So with that, I'm going to pull up my copy so that you all can see it as well. On Rule 1, just to let you know, I do have Bureau of Legislative Research here in my office with me, but they had actually reached out to us. We are deleting references to nursing home consultant pharmacist permits that were deleted in the legislative session from an act, so we don't have references to any fees or renewals or required endorsements on the pharmacist licensure that you'll see on page 1 and page 2, as well as page 4. That deletes the referred fees that had been in statute before, so there is no longer any fee to do nursing home consultant, and there would not be an endorsement licensure process for that. We'll talk more about that in Rule 5. You see the brief change on page 6 regarding that. And then as we get down to page 8, we had been asked by legislative research that there could be confusion with the use of active duty, and therefore we changed that to just be consistent with uniformed service members. That is there in highlight in the title section, as well as sub small a sub number 1 for consistency, in case anyone had any confusion that active duty would or would not include people that are in the active reserves. Those are both non-substantive changes that are being suggested by staff due to public feedback. Everything else in there, we have not had any other feedback at this time. I will ask if anyone who is with us today has any comments in favor of Rule 1 or opposed to Rule 1. I only see one other participant on screen with us currently, but if you would like to raise your hand, we will be happy to let you speak to that. Okay, seeing none, do any board members have any comments on this proposed rule? I know you guys have seen this a couple of times before as we've gone through it.
John,
Yes, sir.
excuse me. Do we need to vote on these individually, or are they something that's done all together?
I would prefer an individual vote for each one. 2 of them we are suggesting non-substantive changes, and therefore we would have a specific vote to either adopt it with or without the non-substantive changes. My suggestion would be for a motion to adopt with the suggested non-substantive changes.
Okay, so is it okay if I call for a vote on that at this point?
Yes, sir. I see no comments extraneous to what we've already seen on Rule 1. We have had some verbal comments, just nothing contributed previously of people telling me this looks good and appreciated us doing it. So with that,
okay, so fellow board members, do y'all have any comments or any motions to entertain?
See Dr. Mack.
Dr. Mack, please go ahead.
I'll make the motion that we accept this as just portrayed through Dr. Kirtley.
with the non-substantive changes.
With the non-substantive changes.
Thank you, Dr. Mack. Is there anybody willing to give a second? And I can't see anybody, so speak up.
I look,
Okay, this is Dr. Newsom. I second that motion, please.
Thank you, Dr. Newsom. We have a second. If there's no further discussion, we'd like to take a vote. All in favor, please say aye.
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 All right, any opposed? Hearing none, so be it.
the second rule that we have up for consideration today is involves changes to Rule 5, long-term care facilities. These will remove the nursing home consultant permit endorsement process as it was removed with Act 63 of 2021. This also had some relation to Rule 1 where we removed the fees in reference to the endorsement. This actually helps to clarify the definition since there will not be an endorsement process. We did have comments that I had already sent to the board from Dr. Ken Lancaster. With his comments, he and I had a great conversation via phone trying to figure out exactly what he was worried about, and I'll point those out. You'll see in the definitions, I had already had language to remove where there was an in charge or an at-large consultant. That is antiquated language that really goes back about 20 years, just to give a definition. And he had a concern that whereas many of these services were done previously within the home while you were on site because it was paper charting rather than electronic, most of our consultants are able to do a large portion of their duties from an office setting or via computer, where they're able to review medication reconciliation records, medication administration records, and medical charts rather than having to do all of that on site. So his suggestion was, instead of saying in a nursing home, for a nursing home, which I believe is an appropriate non-substantive change, which catches what actual practice is going on. You will see on page 2, we actually had a pretty good discussion about an individualized resident record. And through that, and if you really read in this section, it's about supervision of services. Well, the records that would indicate the day the consultant pharmacist visited the home, the statement of purpose, finding, and actions, many of those things aren't necessarily dependent on a specific patient. It's actually overall records and suggestions for the home, working on formulary, working on the way that they process paperwork and everything else. He and I, after we read it, I'm not sure why it would have said an individualized resident record in this subsection before, but it's just changing that to where it just says records actually makes a lot of sense. Dr. Lancaster had some concern that generally in nursing home consulting, they are saying there are some references to where it's specifically to nursing homes versus overall facilities, which link to some of the statutory definitions that are not necessarily consistent either. But overall, he was in favor of it. The last part that I had was on page 3. Additionally, consultant pharmacist shall routinely review each patient's, and he said chart. Some people think that chart only means a paper chart. And I know that the intent for this is, while we would say a chart is whatever medical records are available, the preference was that it would say medical records to define that specifically as medical records, so that someone didn't think you didn't review a paper chart, or that a home thinks that they have to keep a paper chart in addition to the electronic records. Everything else would remain unchanged other than the already suggested changes that are filed in addition to these non-substantive changes. With that, I would see if anyone has any comments for or against this rule change from the public. Not seeing any. Do any of our board members have any suggestions? I know, Dr. Richmond, I think your suggestion was that we continue to review this to see if we can help increase consistency, whether we call things facilities or nursing homes or whatever it may be.
Yes, and there were just a couple of places. I know there may be some difference in intent there, but just one example. First paragraph under section 05-00-003, in the same sentence, it says consultant pharmacist in a nursing home, but then later in the sentence, it struck nursing home and changed it to facility.
Let me
I think
find that.
we
Go
just
back up, John.
go back up
Up a little bit more. Right there.
right there. So it should say, should that not say facility?
That should be a non-substantive change as well. If the board would like me to make that, I'm glad to.
So there's just probably 8 or 10 places that I found that's really all it was.
And what I can do,
Yeah, I can tell you where I found them.
Okay.
On page 2, section A, subsection 4, nursing homes appears twice.
so I know there are some weird specific laws specific to nursing homes, not just long-term care facilities, but I don't think that it is necessarily substantive which one you call this, because they are consulting in more facilities than just homes. So if the board's preference is to be consistent with facilities, that should be doable. Is that the preference of the board?
Yes.
Yeah, I'm okay with that.
Yeah, I think it's a good idea.
Dr. Richmond, where else did you have next for me?
On page 3, about middle of the page, subsection 4. And since ICFs and MR facilities are listed separately, are we referring to here SNFs? Should that say SNF instead of nursing home, or?
No, on specifically nursing homes in the long-term care field, they are required monthly. And there's different, so I mean, it's SNFs, but there's different levels of skilled nursing facilities.
Yeah, and there's an ICF, which would be Medicaid approved, and then skilled nursing facilities would be Medicare approved. And I'm not suggesting one way or the other. I'm just raising the question. That's all.
Okay.
Also under D subsection 1, just a couple of lines below that.
On that one, it is interesting because it is the legend drugs for a nursing home do fall under different rules with Department of Health, where they would not be eligible in some other facilities. Like assisted living would not actually have emergency kits.
Right. Okay.
So I think that one may need to remain nursing home.
Okay. Page 4, section 5. That may say the same thing since it relates to e-kit.
Yes.
Page 5, first paragraph under 0005, there's a couple of places. Since that relates to e-kit, that may still remain the same.
I believe so in this one, because this is the specific kit for nursing homes. When we had changed that one previously, we had left nursing home in it because some people thought that this would mean that these emergency kits were available for any long-term care facility, when the intent was just those skilled nursing facilities deemed to be nursing homes. And I know there's a more technical term, more than likely, but that's the term that we had been given at that time.
Okay. And then the last one, it's on page 6 under e-kits, but for hospice care. So could there be hospice in anything other than a nursing home?
Yes, there are hospice facilities that are licensed specifically as hospice facilities that can either choose to have their own pharmacy on site, which would be like a hospice hospital pharmacy, or that they do not have their own pharmacy and they lend that work out to a retail pharmacy permit. The ones that use a retail pharmacy permits are allowed to have an emergency kit, since they do not have any other non-patient specific drugs on site.
So the way it reads is nursing home or institution. I guess institution facility, that means the same thing.
Yes, that would be the ones that are specifically permitted by the state as a hospice hospital.
Okay, that's all I saw.
Any other suggestions from the board? Okay. Seeing none, I would turn it over to Dr. Kraus. The staff request would be for a motion to adopt with the non-substantive amendments that we've gotten from the public feedback process.
All right. Do we have any other comments or a motion to be made?
I can make the motion.
I'll second.
Okay, you'll go ahead and state your motion, Dr. Richmond, or you want it to be what Dr. Kirtley said?
Well, consistent with what Dr. Kirtley said, I move that we accept these changes, including non-substantive changes as outlined by Dr. Kirtley.
Thank you. All right, we have a motion and a second. Board members, all in favor?
Aye.
All right.
Aye.
Any opposed? Hearing none, it passes.
All right, and I will note that Ms. Rader has also joined us, and then I will pick up with rule number 9 that is proposed. The proposed changes in rule 9 will remove the disease state management endorsement process, which was part of Act 63 of 2021. Will also remove language that is in conflict with Act 406 of 2021 and Act 407 of 2021 regarding the ability of pharmacists to deliver care in relation to vaccine prescribing, administration, and delegation to other support staff. On this, changes will start on page 3 with prescription orders to administer medication and or immunization. I know the board has seen this before. We've received no feedback in writing or anything submitted on this. I know that we had a lot of feedback earlier on in this process, encouraging us to make these changes. Very simply, we are saying except as limited by these rules or Arkansas statutes, an Arkansas licensed pharmacist, intern, or pharmacy technician has the ability to administer medications they have been trained to administer. The statute does limit exactly what technicians can do specifically, but this way, if the statute changes, the rule would not necessarily have to change because it is linking directly to statute. It is deleting all of the other extraneous specific information that does not need to be restated, and is completely deleting the disease state management language, since that is something that is part of the practice of pharmacy in the Pharmacy Practice Act and is spelled out. With that, I will see if anyone online has any comments, either in favor of or against, or clarification request for this proposed rule change. Seeing none, do any of the board members have any comments on this? All right, with that, I would turn it over to you, Mr. President, to see if there is a motion. Staff request would be for adoption as presented.
All right, board members, do we have a motion or discussion?
Motion to
Go ahead.
adopt.
All right, we have a motion by Dr. Newsom. Is there a second?
Second.
Second by Dr. Richmond. All in favor?
Aye.
Aye.
Any opposed? So be it, John.
All right, so that would close out the public hearing portion of this. I also had sent the board just some draft copies of a couple of additional proposed rules from statute. I don't know if any of you had any questions on that. Our request would be for a motion to direct staff to continue the rule promulgation process on those 2 items. And I can pull them up if anybody needs to see them.
Go ahead and pull them up, John.
Okay. The first one is dealing with, let me switch pages on this. My computer's being difficult as usual. Here we go. The first one is in relation to Rule 7. And in Rule 7, what this would do is you scroll down to page 7. This is dealing with therapeutic substitution, which is part of Act 503 of 2021. We were able, John Benson with the Pharmacists Association and I, who I know they were a driving force behind this, were able to meet with the bill sponsor last week. And this is about therapeutic substitution. The therapeutic substitution statute would include language that very similarly mirrors the generic substitution statutes, as well as the way we have it in our rules. One big point of discussion is that there are drugs that should not be substituted. And we have, hold on, let me make sure this is the right version of this. We had 3 or 4 sections that we had said would not be included. It is not on your screen. Hold on. Let me get all this off here real quick. So the medications that we had said would automatically be included via the rule, Arkansas State Board of Pharmacy has determined that therapeutically equivalent medication should not be substituted, has notified all pharmacists of that determination. And what we had agreed to was saying oncolytics, antidepressants, antipsychotics, and controlled substances, especially with controlled substances, understanding that a different person cannot be enabled to automatically change what controlled substance could be made. And there had been concerns over antipsychotics, antidepressants, and oncolytics over time. The language other than that would include that you have the ability of the prescriber to say do not substitute, and the fact that it has to save the patient money and there has to be some notification back. Are there any questions on this at this time?
And does therapeutics equivalence, that means within the same drug class, right?
Yes, sir.
Okay, thank you.
So it's an ACE inhibitor for an ACE inhibitor. You would have to use some sort of clinical guideline to help with that. We've already been in discussions with the association in helping to gear up some specific educational outreach to help guide pharmacists through this. So, and it's already got what we've had previously, therapeutic equivalence may be established with clinical publications comparing dosages of drugs in a therapeutic class. So you can't change an ARB to an ACE inhibitor. You can't change a PPI to a H2 agonist or antagonist. I mean, it's direct therapeutic class substitution. So the board would go ahead and develop some further guidance, and the association, it sounds like, would help with some educational CE to help pharmacists with this as well.
You could substitute Eliquis for Xarelto, but you couldn't substitute Eliquis for Coumadin.
Possibly, yes.
John, where is that exclusion list that you mentioned, the oncolytics?
I have it on paper. I don't have it on screen, but it was those 4 things.
And that'll be, is that an update to this?
Yes, that would be added to this language.
Okay, and that would apply in all settings, right? Not just retail.
This is, when you look at this, this would not generally apply to, like, for you in a hospital setting where there's a formulary that you're already following. They're already signed off on protocols, which would be in addition to this. One thing that you can see here is this section does not apply to specific acts of drug therapy management or disease state management delegated to pharmacists based upon written protocol or patient care plans approved by a physician. So all of our hospitals that have formulary determinations already have that in place. This does not override that.
Okay, thank you.
And I apologize, Brian. I should have actually mentioned that because I know that will be a concern of our clinical settings.
Yeah, and I was curious about, hospital P&T approved
Yeah.
therapeutic subs, if we needed to make sure we took a look at those to align. But you've clarified that we'll still continue that same process to run it through.
Yes, those would all be written protocols within that health system.
Okay, thank you.
John, I also seem to recall that HIV drugs were one of the things that were accepted, EX,
Well,
excluded, in other words.
we have had that discussion in the past. They were not here because the fact that most of those are in combination, and we would expect that in most instances, the prescriber is going to say, do not substitute. But we did not want to prevent the ability for a pharmacist to split out the individual ingredients or to combine the individual ingredients based on formulary preferences of an insurance plan. So if drug A is a combination of drug A or drug 1 and drug 2, if the insurance prefers for you to take those separately, the pharmacist should be able to split those out into 2 prescriptions, if that makes sense. But our hope would be that there would also be basically a campaign to help educate everyone of, this is what's appropriate, but you can't just say you've got this, RTI inhibitor for another one on an established HIV patient, and the patients are likely not going to agree to that either. So the patient still has authority to refuse this. The prescriber has authority to refuse this as well. Any other questions on this subsection? And we'll get other feedback from Department of Health, from the governor's office on this prior to even being able to publish this for public comment. And I'll send you guys the updated copy for filing that has the exceptions. At the end of this rule, we also had Act 922 that would require the board to set up some kind of prescription delivery standards. So we were able to meet with some interested parties last week, the association and some people that are heavily involved in actually drug delivery, and have also sent this to some of the corporations. This is kind of the base list. Initially when I wrote this, I had some other stuff that was pointed out could be extraneous or in conflict with other things. This is what we have come up with thus far that seems to be accepted and palatable to everyone. You got to contact the patient or caregiver for approval prior to billing it to the patient or delivering it to the patient, so that kind of what the plan is for the delivery and expected arrival. Ensure medications will be maintained within appropriate temperature guidelines. I'll tell you that at first we said according to package insert, but if you look at package inserts, some of them are absolutely terrible, that they don't say anything other than normal temperature. They don't address allowed temperature excursions or anything else. So have a plan for that. And if there is a complaint to the board that it wasn't done, then the board would examine what is the plan to ensure that it was, especially in refrigerated items, refrigerated all the way to delivery. Arrange any controlled substance to require proof of delivery, so proof that they were actually delivered. Plan in place for local medication supply availability when delivery cannot be done in a timely manner to maintain the patient's ongoing therapy. This is something the board has expressed frustration with in the past. We have had some cases where patients had undue delays in deliveries. And if you were having to get it from elsewhere, then asking that pharmacy that they must have a plan to help get a patient the emergency services that they need when they cannot get their prescription shipped to them in a timely manner. Part B is basically mirrored directly from the statute that states a pharmacy or pharmacist owns or controls, own or controlled by, is under ownership, control with an insurance company, PBM, or so on. They shall not require that a patient receive his or her prescriptions through home delivery services. So I don't know exactly how that's going to play out, since that's a direct statutory language, But in many ways, it means you cannot have a closed door only pharmacy if the patient wants to come by and get their prescriptions. There are some other arguments I know the association may have about the fact that an insurance company can't just force mail order. But the gripes we have are, well, it costs different one place versus another, and we have no control over that. Dr. Jolly?
John, does this apply to specialty pharmacies dealing with limited distribution network drugs? And how do you establish a plan for local medication supply if there's a restricted network for availability?
There are some instances where the plan in place for local medication supply may just be what is the closest other place where that limited distribution drug may be available. I imagine if that comes up much, that there will be a push, not necessarily from us, but potentially legislatively, of those medications have to be available at more than one source. But there are some medications that you just can't get other than from one source due to the manufacturer.
Right. So out-of-state specialty pharmacies are going to be subject to the standard as well?
Yes. It's anyone providing these services in Arkansas, which would be into Arkansas or within Arkansas. Any other questions on this? Okay, the other one I have is Rule 9. The easy way to define this is point of care testing. As you guys will probably recall, Act 503 that becomes effective January 1st of 2022 has language about pharmacists testing and treating directly. The two issues from the initial draft I had done that some of you may have seen previously is on line 2 of subsection A, substituting instead of reporting a diagnosis or suspected existence of influenza. I'm pointing this out because that's the way it reads in the statute, but meeting with the bill sponsor as well as with the Pharmacist Association who helps support this, the fact is there are other reportable diseases such as COVID-19 that the Department of Health would want to know. So we would substitute language there, report a diagnosis or suspected existence of a reportable diseases as required by Department of Health. And then the law spoke very specifically for influenza and pharyngitis caused by Streptococcus A. In that, we would also go ahead and add COVID since there are federal guidelines and it is open federally for that. So that if and when PrEP Act language goes away, that we already have statewide protocols set up. This would all require that any protocols that we come up with, you'll see here, section C, they have to be developed and adopted with consultation and approval of the Arkansas State Medical Board. It shows exactly what, according to the statute, has to be included in those protocols. So this is step 1 of getting these rules in place. Step 2 would be the rules allow for the protocols, and the protocols must be agreed upon with the Arkansas State Medical Board, which that is direct from statute as well. Dr. Mack?
So how hard is that going to be if it says just Streptococcus A? Is that going to be a little bit hard to?
That's what the statute says, and that's what most of those rapid tests are testing for is Strep A.
Strep A only is all they'll test? Okay.
Yep.
Because I didn't know if they could be testing for more and then it doesn't specify.
If the board wanted to expand to other disease states at a later date, there is a method to, you'll see on number 4, other health conditions adopted by rule according to the Pharmacy Practice Act, meaning it has to be adopted by rule. And then you would have to have a protocol in this same method that's written and agreed upon by the medical board. I would imagine, and in our discussion, many of these things, you're going to have people that will test negative that are symptomatic. And what we have seen in actual practice, even currently, is normally these tests end up with a very large percentage of people being referred to their primary care physician, or if they don't have a primary care physician, to helping them establish a primary care physician or other primary care health source, whether it be a PA, an APN, or whomever, so that they can get additional care. Because many of the people that, test negative are symptomatic and otherwise have things going on and need to be seen further. Many of the people that test positive also still want to or need to be seen by their primary care practitioner.
John, Dr. Kirkland.
Yes.
I'm sorry, excuse me. And this may be really dumb, but in looking at number 3, going back to COVID, when I look at that, I think of that almost like a brand name. Should that be coronavirus and its variants or something like that?
We had discussions that we did not want to put it as COVID-19 because it's, coronavirus variant. But one suggestion was to have SARS-CoV or COVID or, coronavirus. But there's a whole lot of coronaviruses that have no testing whatsoever. Right now, the only ones I'm aware of with specific testing and approved treatment are COVID. So we're having that discussion, and if we come up with different language through filing this, I imagine Department of Health may have some feedback on that as well.
Well, I'm just saying, we got influenza, that covers a lot of things.
Yeah.
We got strep A, that covers a lot of strep. I mean, not all, obviously, but
Yeah.
I mean, it covers a whole line. And I was just wondering, well, COVID, it could be looked upon later as being rather narrow in scope. But anyway, thank you.
What
Also,
about,
go ahead.
this may be a little picky, but under section C3, should we include Schedule 6?
Well, the problem with Schedule 6 is many pharmacies refer to Schedule 6 as everything that's non-controlled. In at least 2 practice settings that I practiced in previously, everything in the computer that was not a control was actually shown in the computer as Schedule 6. So Schedule 6 is a weird anomaly of Arkansas that is broadly considered in a different way. Like antibiotics in most pharmacy systems are shown to be Schedule 6, which means non-controlled. It is the weirdest thing, but it also does, the statute did not include Schedule 5 due to the fact that there are the historic, Schedule 5 products and pseudoephedrine that are not even necessarily prescription.
Is there any reason to say then Schedule 1 through 4 and medical marijuana?
Well, pharmacists don't have the ability to prescribe medical marijuana, and actually no one prescribes medical marijuana. It's, you get a signature of qualification to get a card from the Department of Health. I know exactly where you're going. We actually have laughed about that some of, I don't think that influenza, pharyngitis by strep A, or COVID are actually a qualifying medical condition for a medical marijuana use card.
At least not yet.
Not at this point. Dr. Mack?
That's what I was going to say.
Sorry, back on B and 4. So today there isn't any other health conditions, but at a later date that's open. So if we wanted to come up with one,
So
or somebody wanted to.
the discussions that we had with both the sponsor and with the association, although I'm sure there are other things that people would like to do, I feel fairly strongly that we should tackle what we can do in the immediate to get it going. And
Right.
then if there are other disease states, that brings up a whole different conversation of, these are basically captured by either state or federal law currently versus something else that could derail the entire process.
Yeah, I think getting these would be huge, and that's important. I just want to know, that just means at a later date
Yes.
we could do it. And then as far as the oral contraceptives, since they're not test and treat, they're just a whole separate program, that'll be like a whole separate written up article.
those did not require a rule change. Actually, from that statute, it is very specific. So I have language that's developed and have I guess made requests that is stuff that I know we have people working on currently to bring before the board at a later date. I can send you, I may have sent it to you before, I think I have, but I can send you my overview on that statute and what all it requires, but it does not include rulemaking.
Okay.
And John, this may be, because it falls, this is under point of care, so, but just the question as things come to mind. I know the health department can dispense, drugs for STDs and TB. That wouldn't go under here.
Well, the health department has some specific language for PrEP as well as for TB. I'd have to even search to see what CLIA waive tests there are for those that would apply in point of care treatment.
Dr. Kirkland.
Yes, sir.
So the last one there where we can add to it as needed down the line, what would be the procedure for that? If we did come up with something and say, well, we're going to do some drug monitoring, or we're going to do some new disease testing or something like that. I don't know, but what would be the procedure to add to that? I know it says it, but would it still be a very onerous procedure to do it, or is it something we could do as a board?
Well, it's something we could do as a board, but it would be saying, here is another disease state that has a CLIA waive test available to treat something that we would like to add to the list. Then by rule, we would add it to the list, and then we would have to have a protocol that would be agreed upon with the pharmacy board and the medical board in order to be used in the state of Arkansas as a statewide protocol. So there's some things like we've had people throw out, it's like, well, we should be able to test for diabetes. And I mean, blood glucose test and A1C are, CLIA waive test, or even tests that individuals can do themselves. But in general, if you have someone that is diabetic, it's a greater level of care than a short episodic treatment for pharyngitis, influenza, or COVID. So there's a process. The other thing that we discussed in our meeting last week was, well, if there is, you have to figure out if there is a method to have a protocol, and if it is a protocol that can be agreed upon between the medical and pharmacy boards.
And have we had good luck in working with the medical board to reach these goals?
Well, this is new for us. We have, this is exactly what we did with naloxone previously.
Mm-hmm.
Worked well.
Thank you.
So our request today is on these two rules, basically for the board to direct us if we are okay to start the promulgation process for approval through Department of Health and Governor's Office to lead towards public notice and hearings similar to what we've had. And we'll keep sending you guys versions of this with any updates in case you have individual feedback for me on them.
There'll be a 30-day comment period for these as well.
There would have to be. At this time, it may be, it will be some period of time before we would even have the ability to file for the comment period.
John, could this section also include down the road potentially like point of care therapeutic drug monitoring?
I would think that would already fall under potential disease state management, or MTM, but we'd have to discuss some specifics of exactly what you mean. This is
That's kind of
another,
what I'm thinking, Rodney.
What's that?
this is
I
This
said
is
that's what I
all-
was thinking too.
Yeah, this is a whole nother thing that would not be, this subsection does not apply to specific acts of drug therapy management or disease state management delegated to a pharmacist based upon a written protocol or patient care plan approved by a physician. We have that phrase in this one as well. We already have pharmacists that are currently doing that as disease state management.
Well, I'm thinking pharmacogenomic.
True.
I guess that's what I didn't really complete my thought, but that's what I had
Yeah.
in mind.
Well, and a lot of pharmacogenomic is going to be counseling on why medications may or may not work for you specifically, rather than actually changing the management. A lot of times it's education.
But for example, could a pharmacist change a dose based on point of care genomic testing?
Yeah, I think that would fall into disease state management at this time. I think it may be different than just point of care. Most of the genomic testing isn't point of care CLIA wave testing. Dr. Mack?
So is the immunization one completely finished, or is there more information to do on it? Where we took the prep back in?
You guys voted this morning for us to proceed with the changes on Act 406 and Act 407 in Rule 9, which would be all the immunization language. So that will continue in process. I will be filing that with legislative research, and then they will schedule us for for rules overview at the Capitol.
So there's still more to go. Okay.
There's more steps, yes. Do you guys have anything else on this?
Any other comments? Dr. Kirtley, you got anything else to add?
Nope. Just if you guys want us to proceed.
Can I entertain a motion?
Uh,
Is that Dr. Newsom?
Make a motion that board staff continue to work on these two items.
I'll
Yes.
Thank you,
second.
Dr. Newsom. Got a second? And who is that? Dr. Mack?
Yes.
Thank you. All right, all in favor?
Aye.
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 And any opposed? Thank you very much.
Okay.
Seems to pass.
Guys, that is all I have for today. I appreciate you spending part of your morning with us. Anything else you have?
Merry Christmas to everybody.
Absolutely.
And congratulations to John.
Yeah, that's what I was.
Yes.
gonna say.
Yeah, big congratulations.
Yes.
Thank you, guys.
Maybe I missed the news. What happened?
I was named
Hello.
an APHA fellow.
Great job.
Somebody told me I've got to go get new business cards. I said, well, it'll only take take about 10 years to get rid of a box. Nobody wants my business card. Well, thank you guys once again for being with us this morning. I think this is some great progress with more to come, and I'll keep you posted for anything else that happens on all this.
And I know it's been a lot of hard work on that too, John. So thank you.
It's been fun. All right. Thank you, guys.
Thank you.
See y'all later. God bless.
Yeah.
Bye-bye.